it's Sarah here from BJC Health, coming to you from Sydney, Australia. Thanks for showing an interest in one of our educational events. You're about to watch part one, so enjoy the event. If you've got any questions about the content, then please consider joining BJC Connect, where you can access all of our facilitators live. Otherwise, please consider leaving a comment and we'll do our best to get back to you.
All right, so a little bit about me. As Sarah mentioned, I am very much into rock climbing. Spent a bit of time working with the Australian climbing team, which took me around the world, which that was very cool. And some experience in a rheumatology practice at BJC. And currently my area of interest is pain. So studying a Master of Pain Science and very neck deep in assignments at the moment. So having to read a lot of literature. Okay, next slide. Okay, so could we put the pictures smaller so that the slide can be seen? Is that?
It might be your setting. You can potentially move your window over. I can see your slides nice and clear. So normally it just sets it up so they can, you'll be good.
Everyone can see them?
Yeah.
Okay, cool. Yep. So we're going to be covering a few main things. So understanding chronic pain. So why does some pain become chronic? Some recent research and advancements in management. So some things have been changing over the last few decades. Unfortunately, we're a bit slow on the uptake in the medical profession, but we're getting there. Some physio intervention. So as Sarah said, and I've mentioned, I'm a physio, so that's my special area. Tailored movement strategies and looking at how exercise specifically can help reduce pain. So I'm sure Sarah will have some things she'll be able to share about that as well. And kind of thinking beyond medical management. And I'm going to talk to the topic of active self-management strategies regarding that. So what we can do pragmatically in these situations when maybe we've got there's a health driver for that persistent pain, a diagnosis of rheumatoid arthritis or things that are ongoing that we're going to have to, keep managing and looking at how we can do that more effectively. So thought I'd just cover some quick facts on persistent pain. The 75% of people with chronic pain are of working age. So these are some stats from Pain Australia. 2.95 million Aussies with chronic pain will be limited in activities due to that pain, which is a pretty huge figure considering our population size. 63% of those people are using opioid medication, and there's been a lot of talk about opioids in the news, and you go on Netflix, there's series about this kind of stuff at the moment, so we know that they can be, while they're very useful, but also very harmful. People with chronic pain have experienced depression and anxiety at rates 4 times higher than the average population. And what we'll discuss a bit later is, that's a very bidirectional relationship. So, the depression affects pain, but also pain conversely causes depression. So, another staggering one. In Australia, it cost us $144.1 billion in financial costs in 2020. So it's something that I think we sort of really underestimate the broader impacts of persistent pain, and that we're not really possibly managing it as well as we could be. And so, why are we facing such an epidemic of chronic pain? And I think you're all here, you're all interested. So I'm sure you would all personally have maybe some experiences you could share or some insight into that. But we're going to talk a bit more to that regarding the definition of pain, because we only recently actually updated that. So this infographic was released by the International Association for the Study of Pain. So that's our international body that does all the research and information sharing and investigation into pain management, treatment, identifying varying types of pain. And it's taken us 4 decades to update the definition, which is kind of crazy, considering how much research has happened in that time. So the primary difference that we can see here is we used to just have this nice little sentence. So back in 1979, an unpleasant sensory and emotional experience, it's associated with actual or potential tissue damage and described in terms of such damage. So really emphasizing tissue damage, as a main driver for pain. And I don't know if in all of your experiences, but, we know that we don't necessarily always need to have tissue damage to have pain. And we look at instances of conditions like fibromyalgia, or even complex regional pain syndrome, the majority of low back pain, there isn't any specific tissue damage or structure that is driving that pain necessarily. So eventually we got our act together and we updated the definition. And so the primary difference there, you can see that they're saying it's associated with or resembling that associated with actual potential tissue damage. And they've emphasized that it's not necessarily associated with, it could be resembling. It doesn't necessarily need to have tissue damage to occur. And they've also added these extra pain notes down the bottom. So you can see pain is always a personal experience, and it's dependent on biological, psychological, and social factors. They talk a bit about pain pathways and the fact that we don't actually have things called pain receptors. There's no such thing as a pain receptor. They just simply don't exist. We have nociceptors and they're receptors of dangerous stimuli, things like, really hot things or cold things, sharp things, things that might be associated with tissue damage. But those receptors can be active even in the absence of tissue damage. So we can't have pain solely from those receptors being activated. And so we've had to be really careful in changing our language. We no longer use that term pain receptors. It talks about life experiences. So life experiences shape our experience of pain. And what we've learnt over time, so in our youth. We need to understand that a person's report of pain should always be taken seriously. So the only way as a physio that I know that you're in pain is if you tell me. There's no scan, there's no test, no nerve conduction study, MRI, blood test. None of that can tell me if you are in pain or not. The only way any clinician can know if you are in pain is if you tell them they're in pain, if you tell them you're in pain. And if you say, I have a 20 out of 10 pain, you have a 20 out of 10 pain. I'm not in any position to tell you that your pain is any less than that, or somehow try to get you to change your scale. How you define your pain is your personal experience, and that needs to be considered. If a patient's telling me they're in 20 out of 10 pain, maybe 15 years ago, I might have said, oh, this person's having you on. They're exaggerating their pain a bit, maybe they're catastrophizing. But nowadays we understand, well, actually, if they're telling me that, what's the driver for that? Is that related to the suffering they're experiencing related to their pain? Is that because pain has stripped them of all their quality of life? Is that because they're not sleeping, because their relationships have broken down, because this pain has impacted on them in a more broader sense? So we're really undergoing a massive shift in how we're understanding pain and how we're responding to our patients. And so this change in definition has been really helpful for explaining that to other health professionals and patients too. So get the next slide. Right, so chronic pain. What is it and why does it occur? So Pain, we understand, serves a protective function in our body. So typically, you injure yourself, you'll get some pain. You sprain your ankle, hopefully you'll have some pain, because that's your body's way of telling you something's going wrong in the outside of your ankle and you need to do something about that, right? You need to slow down, slow down that loading, let those ligaments heal, let things stitch back together. And typically, as things are healing, that pain response should start to settle down. So what I'm describing there is acute pain. So usually closely related to some tissue damage, and usually responds, as the tissue healing has gone through its phases, the degree and severity of that pain should diminish as well. However, we can experience pain beyond the normal tissue healing timeframes. And that's what we would define as chronic pain or persistent pain. You might hear me use the word persistent pain, and that's because I think it infers that it can change. So chronic kind of feels a bit like, oh, that's it, me forever. I'm going to be living with this and managing this forever. But persistent pain, it's kind of like, oh, okay, it's hanging around, but there is some possibility for change. But chronic pain, largely pain that lasts more than 3 months. And so any pain that we have that lasts more than 3 months, this is our best definition of chronic pain that we're working with at the moment. We know it can typically happen as a result of poorly managed acute pain. So say someone injures their ankle at work and they're in a fairly stressful scenario. They've had to take some time off work. They're on workers' compensation. They're, maybe a diagnosis got missed initially. They got pushed a bit too hard, a bit too quick. They ended up on some strong pain medications. Their sleep started to go out of whack, and so on and so forth. And it hits that 3 month mark, and okay, those ligaments have healed, but that person's still really suffering and in a lot of pain. So that can be a factor in contributing to chronic pain. But largely we look at it from this sort of perspective of what we call the biopsychosocial model. So biological factors that might be contributing. So that could include the injury itself. Maybe it didn't heal up so well. There might be some ongoing comorbidities like diabetes or obesity kicking around, other illnesses, different factors there that can certainly contribute to chronic pain. Then you've got environmental factors. So things like, what's that work environment like, sleep quality, all these other kinds of considerations, they all have an influence on the pain experience. Psychological factors, so stress, anxiety, depression. Oftentimes, at least the patients that I work with, they might not necessarily have had symptoms of depression and anxiety before their pain started, but certainly the longer it persists, the more it starts to affect their mental health. And so they might then subsequently develop some of these mood disorders. And then those mood disorders start to negatively impact their pain. And so it goes in that cycle, which I think often can be a source of stigmatization for some people living with persistent pain, that it might be sort of suggested that that's somehow all in your head, that you're imagining it, that the only reason you've got pain is because you're depressed and anxious. Well, actually, you really need to disagree with that. Okay, yes, those factors contribute, but that person probably wouldn't have depression and anxiety if they weren't in pain. So, it's a part of things. And I think that's why this diagram's quite good. I like to think of it like a pie chart, and you break it up into lots of different pieces. And some factors may be contributing a lot more than others. So, 50% of that pie chart might be related to ongoing tissue injury. But then you've still got 50% left, which is significant. And then that's where your social factors, psychological factors, environmental factors creep in. So we'd be missing out on a great therapeutic target for reducing pain by not considering that. So social factors is probably the last one on that list. Pain can be really isolating. The more you're in pain, the less you want to go out, the less you want to talk to people. It's frustrating. People are always asking, oh, how are you going? Are you better yet? You know, have you got, you know, if you're back to work yet? And yeah, it's really frustrating to have to answer those questions again and again and explain, oh, no, I've still got pain and no, I'm not back to 100% yet. So often people they just don't feel up to it. They might not be sleeping well, so they just don't have the energy. And because of how it's impacted on their mental health, you know, they really just don't feel up for it. So yeah, and definitely in instances where there's that lack of support or maybe some ongoing family distress or breakdown of relationships, certainly see these factors immensely impact on people's pain experience, and yeah, really negatively affect their prognosis actually. So having good social networks, having good support, you know, and working through some of those things happening within the family environment really can influence positively in improving pain. Right. I need to make that smaller for a second because I can't see it all.
Even with your glasses on.
I know. Yeah, I need to get my vision checked.
But that's okay. All good. And just remember, everyone, you can hopefully adjust your own view so that you can sort of see less of the people here and more of Justine's slides, if that's helpful for some of you as well. But hopefully you can see what Justine's about to go through.
Yeah. Cool. Let me see if I can make that big again for me. Great. So this slide, I'm not going to read all of it out to you, but this is a model that was put forward by some researchers who we're going to discuss a bit later, looking specifically at low back pain. So it's just a bit more of a comprehensive view of how all of those factors interact there. And you can see there's arrows that are going both ways. So they're going, you know, in multiple directions here. So I think that the gist of what I'm trying to get across with explaining what is chronic pain, well, it's all of these things. It's complex. It's not simple. And that's why our best treatments available now are, you know, multimodal. They involve lots of different disciplines. You might be seeing a physio, you might be seeing an EP, you might be seeing a dietitian, a pain specialist, a rheumatologist, a GP all at once when things are bad. Because we really need to consider how, for each individual, how all these different factors might be influencing their pain. So we need to individualize that care, really importantly. And just to speak quickly, because I did sort of bring this up earlier, because a lot of my patients do experience this sense of stigma related to, they might have some diagnosed mental health things going on, stress, anxiety, depression. And I think this diagram really captures it nicely of exactly what we mean when we say that it involves the brain when we talk about pain. So stress is not just in your head. Stress is a physical response in your body. So this diagram sort of showing us when we're stressed, the brain actually shifts blood flow from your frontal lobes. So shifts blood flow away from that area and into your amygdala, into that limbic system, the amygdala, these areas that are involved in fight and flight responses. And as you look towards that right-hand side of the screen, you'll see what's affected. So your muscles are affected, your blood flow, nervous system, heart, GI tract, your bladder and bowel function. And the symptoms you might experience, it could be pain almost anywhere in the body, tingling, numbness, burning, irritable bowel symptoms, palpitations, rapid heart rate, headaches and migraines. And over time, the more that we are going through these cycles of stress related to pain, because as you can see, you follow it around, the nervous system really learns these symptoms. So it'd be naive to think our body doesn't learn from the inputs we're giving it. So the more that we're exposing ourselves to these constant stresses, frustrations, anxiety, not having good ways to mediate that, it affects us physically. So it's not just in our head. And that's a really important point to emphasize. And it continues in this cyclical pathway until we get a little bit better at recognizing what's going on. So this is a good question. Is chronic pain forever? Because the term chronic kind of implies that, right? It's like, okay, chronic, I'm going to have this forever. But what we know about and what we've learned about how pain works in the body is that actually our body is amazingly adaptable and changeable. And a term we use for that is called bioplastic. So it's always changing. Cells are always growing and dying off all the time. And if we can give ourselves, much like if you think of the analogy of a garden, if you're giving yourself that right environment, or at least making the environment as best as it can be, that's where you're going to really see things flourish. And in this respect, it would be reduction in your pain, or at least an improvement in your quality of life and how you're coping with that pain. So the main things that I suppose to cover here is education. So number one, and this is what we're doing tonight, really kind of starting to learn how pain works and that it's complicated. But the beauty of it being complicated and there being so many factors is it offers so many therapeutic targets for treatment. So we don't just have to look for surgeries or injections or medication to treat pain. There's so many things that we can be doing that can really improve the severity of the pain and your quality of life, which I think that's the crucial bit. Medication, obviously, as I was chatting about earlier, we really do want to reduce or limit our use of opioids. So, trying to sort of engage in maybe multimodal analgesia, which is where we're looking at taking maybe a few different kinds of analgesia and limiting the use of opioids in particular. So trying not to just have opioid medication. Most GPs and doctors these days, there's been some changes in legislation. So they are sort of really cracking down on the use of opioids. And largely that's not to punish people. It often can feel that way. I've seen that happen to patients of my own. But we know that long-term use of opioids is not recommended for chronic pain. They're amazing medications when used appropriately in the context of acute pain. So thank God for opioids when you have a surgery or, you have a pretty traumatic injury and you're in hospital. Thank God we have these medications because they are so effective. But what we see is even after a few days of taking these medications, your body is already adapting in quite negative ways. So it affects our cognition. We can get a bit fuzzy thinking. It can actually also increase our pain long term. So there's a syndrome called opioid-induced hyperalgesia. Isn't that a mouthful? But the medications themselves start to drive processes in the nervous system that really make your nerves and that whole pain system much, much more sensitive in the future. And you start to build up a bit of tolerance to it too. Not to mention that physical dependency that happens. And the reality is these medications are highly addictive. So we really try to steer clear of long-term use of opioids for those reasons. Active self-management strategies. I'm going to chat a bit more about that later, as long as we've got time. I could talk about this all day. Psychological treatments. So we know, as I was showing you on that slide earlier, stress is a really major contributor with persistent pain. And obviously having chronic pain affects your mental health. And then bidirectional, it works back the other way. So ensuring that we're, addressing how that pain is influencing your mental health, how you're coping with the stress of dealing with that pain every day, and the implications that pain has had for your financial situation, your relationships, your goals in life, all of these really important things. We really need to make sure we're supporting our patients with treating those things. Relaxation techniques, that's important. You don't all need to become meditation gurus, but things like mindfulness and meditation, which is different for each individual. Some of my patients have fish tank, and that's their form of meditation, sitting there in the evening watching their fish. So it doesn't need to be full on yoga style meditation. It can be whatever works for you, but all of these things have therapeutic benefit in reducing pain. We want to take a function focused approach. So if we focus our primary efforts on just trying to reduce pain, we tend to get caught up in some cycles of, lots of medication, interventional procedures, possibly surgeries that may be unnecessary. So where we can, really try to get to the crux of what your values are. What are the things that are important to you? What activities do you want to get back to if your pain wasn't in the way? And start to set a really sensible plan about how to gradually increase and work towards that. So we work on a basis of very short-term goals, which might be, a week or a few days even at a time, and try and really break that down in a way that is going to help you take steps each day back to where you want to be. A couple of things that are hot topics, gut health. So we know that there's absolutely relationships between our gut microbiome and the health of our joints. We know that processed foods contribute negatively to systemic low-grade inflammatory responses within the body. So keeping our gut healthy, eating good healthy food, and if you've seen Monica talk on BJC Connect, that would be a great resource to learn how to do that. And the last one there, virtual reality. So that's been a really interesting thing that has been sort of floating around for the last few years.
So you've just finished watching part 1 of one of our recent educational events. Hope you enjoyed the content. If you'd like to access part 2, then you need to sign up for BJC Connect. It's a free platform where you can access not just the recordings of past events, but also access a whole range of upcoming future events and access our team of facilitators live. All of the details that you need to join BJC Connect are now flashing up on your screen. Otherwise, like our staff, subscribe if you'd like to see more information from BJC Health. Look forward to seeing you in an event soon.